Okay, well, I make it 2 o'clock. Welcome everyone, as I said, to the George Eliot Board. Delighted to see so many of the public with us today. As a board, we've spent our morning workshop going through the various different bits of work which are going on to deliver our operational and financial plan for the year ahead, which I'm sure on behalf of the whole board has given us all a lot of assurance about the actions and progress we will make to deliver better service to our citizens in the year ahead, and a better financial performance as expected by the NHS. It's a very demanding plan. For example, we are expected to deliver 118% of our pre-COVID elective capacity. But I would like just to congratulate, under Catherine Free's leadership, the executive team for all of their hard work in putting that plan together. It won't be easy, and certainly with the uncertainty around strike action, that is our main area of risk. But I'm very confident in the executive's ability to make it happen. Got an interesting board today, and I will keep things moving on as I normally do. So first of all, we have apologies for absence from Gertie McPhillip, and therefore Sarah is joining us and deputising. Thank you, Sarah. Any new declarations of interest? Would you care to raise a digital hand if you've got any new declarations of interest? Okay, can't see any digital hands raised, so I'll take that as a no. The last set of minutes held on the 4th of April, were there any points of accuracy that colleagues would like amended? Could you please raise a digital hand? Otherwise, I'll take them as accurate and duly sign. Okay, I'll duly sign those. Thank you very much. So in terms of action points arising, we go to page 16 of our pack, and most of these have been taken account of. The first was for QAC to investigate whether George Eliot patients were experiencing similar concerns with pathways not working as intended, and the action points given there, and that was complete. We also had Gertie and Robin to assess whether the risk score for frontline staff going on strike was correctly reflected. That was agreed at the Executive Risk Committee and was completed as well. Thank you. We then had a discussion to be taken offline to agree future mechanism for reporting both the annual self-certification G6 licence and the FT4 corporate governance statement. That was handled. Thank you for doing that, Sarah. Then Glenn to update the board on the outcome for discussions regarding our diagnostic performance in the single operating framework. Glenn, you're going to give a verbal update on that later.
Yeah, I can do that now, if that's okay, Russell.
Super, that'd be great.
Yeah, apologies, there's a pneumatic drill outside my office, but I'll try and rise above it. So we've lobbied a bit on this, and I'm pleased to report that from the end of May, there's been a change to the way that the soft indicator works regarding diagnostics. Previously, it was based on the volumes of activity compared to the 2019-20 year before COVID. And now it's moved to an indicator that's based on performance against the 6-week access target, which is a much more relevant comparator between organisations. So we perform much better on that indicator.
Okay, great. Thank you, Glenn. That sounds all much more sensible. Then we had the issue of a small number of improvement themes off the staff survey results. We had quite a lot of time on the staff survey this morning, but that's the next thing on our agenda. So thank you in advance, Sarah. Then Anil, in his capacity as charity trustee chair, to take forward a proposal to support the procurement and planting for trees for every person who's died and for every baby born in George Eliot's care. I know, Anil, this is turning out to be more problematic and expensive than I'm finding elsewhere. So perhaps you and I could take it away, because I don't want to lose the momentum on that, if that's okay with you.
That's fine. Thank you, Chair.
And then some older ones, both of which are complete, which was Hack, Robin and Gertie to liaise with counterparts in the group around developing a regular measure in the IPR to show the level of full-time equivalents. That's being handled via the weighted activity unit per full-time equivalent. So thank you for doing that, guys. And then finally, the final version of the plan would come back to the board for final ratification. That's on the agenda. Are there any matters arising that colleagues feel I've missed? Can you please raise a digital hand? Okay, super. So we'll move then on to the staff survey improvement report. Sarah, over to you.
Thank you. So I'll take the report as read. We identified 4 areas of focus from our staff survey results, and there are some specific actions that we've taken as a result. So, for example, we have increased senior visibility. So Catherine now does a walkabout with each of the execs each month. She does the open house, and we have the leadership forum. And at all of these things, we're talking about the staff survey, so reinforcing the importance of completing it, and what's happening as a result of what we've heard from the staff survey. We now offer exit interviews to all of our leaders with somebody outside of their immediate line management, so that we can understand the issues and the reasons why people are leaving, because unless we understand the issues, then we can't address them. As we discussed at workshop this morning, we held a senior leadership team workshop, which focused on freedom to speak up and what we'd heard through the staff survey, recognising the impact that our behaviours have on others, and the changes that need to happen in order to change the culture. We've put freedom to speak up training on the front page of My Learning to make it easily accessible, and we will be having a discussion at People Board about mandating that at the level that's appropriate for individual roles. We've developed the People Board so that we've got the right executive support and attention to the workforce issues, and each directorate's developed an action plan in response to the local issues raised in their staff surveys. But all of them include an action around culture, and that feeds into the staff, into the People Board. All our new starters and who have line management responsibility now undertake management induction as part of their induction on joining the organisation, and that focuses on our values, behaviours, and enabling and empowering people to speak up. And finally, we're reviewing all the incidents relating to aggression that have been reported. So whether that's from patients and visitors or from other members of staff, to identify if there are any themes, any particular areas of concern, and to look at the actions that were taken and the feedback that was given to individuals when they raised those concerns.
That's a great sum. Thank you, Sarah. I mean, I would just like to sort of put on record the board were concerned and anxious about the issues of bullying and emotional or physical aggression towards our staff, either from members of the public or other members of staff. And we did talk about the importance of being kind and being polite in all of our interactions. But for those members of staff who are feeling bullied in any way, I would strongly encourage you to speak up. You don't come to work to feel that way. We as a board want to support you very much, so please do reach out to us through the Freedom to Speak Up channels if you're feeling unable to do it through the normal mechanisms. Glenn, before we move on, is there anything you wanted to add to that?
Yeah, I mean, it's a really, really good summary. Thank you, Sarah. I just wanted to pick up on the issue that we discussed at a previous board meeting around the completion of exit interviews, reason for leaving. Have there been any specific interventions to try and increase the level of information we get back?
Yeah, so like I say, we're now offering them to all leavers from somebody outside of their line management. So people can elect to have an exit interview with a member of the HR team or with somebody from Freedom to Speak Up or a member of the health and wellbeing team. So trying to make it somebody who is potentially more independent, if you like, to try and encourage people to be honest in the feedback that they're giving us. So Justine Whitmore has been leading on a piece of work on that, and we are starting to see better response rates. So I'll bring that through the people report that I take to QAC.
Okay, great. Thank you, Sarah. Can I just ask, if you're a guest to today's board, could you please turn your cameras off so we only have board members with their cameras on? That would be great. Thank you. Any other questions or perspectives to Sarah? Okay, great. Thank you very much, Sarah. We'll then move on to the minutes of the Foundation Group board meeting held on the 3rd of May. Just for those members of the public who might not be so familiar, every, well, 4 times a year, we have all 3 boards of the Foundation Group, which is obviously the George Eliot, South Warwickshire University Foundation Trust and Wye Valley Trust, come together in a public board meeting. We have a private workshop in the morning, but it's far more of an opportunity for us to compare and contrast performance metrics across the Foundation Group to identify areas of learning and opportunity from one another. I really would encourage members of the public to come along to those. They are really, I think, quite educational, and those members of the public who do come to them, I think, often comment on how useful they find them. But the last set of minutes are here from the 3rd of May. Any points on accuracy from colleagues on that? Please raise a digital hand. And there's only one action point arising, thank you, which is regarding the analytics work that goes on behind the scene. And that's ongoing with Jane Ives and Hack. So Hack, thank you for your work on that. Are there any matters arising that you feel I have missed? Okay, so for a number of us, it's the highlight of the month, which is the Chief Executive Overview. So Glenn, over to you. What would you like to pull out?
Thank you, Chair. So the report is there. I'm sure everyone's read it. I'm just going to pull out some highlights from it. Firstly, the impact launch, which is the national approach to improvement. Really pleased to see the way this has come together. In fact, in our last 3 boards meeting, we had a presentation from Julian Hartley, who's now the Chief Executive of NHS Providers, who was the Chief Executive of Leeds Teaching Hospitals, who did this piece of work last year, and you can see the outcome of that captured in the report. In summary, it's not favouring any specific improvement methodology, but it reinforces the importance of every organisation having an improvement methodology, increasingly looking at the way that that works at place rather than just within individual organisations, but also recognising the fact that culture tends to be the thing that drives this. So if the culture's good and the methodology is good, then you'll get great results. So and we spend a bit of time looking at this at the improvement board, which I'll come back to later on the agenda. Then I'll report back on the virtual group improvement conference, which is a fantastic event that took place between the 15th and the 19th of May, coordinated by Lindsay McLean at Wye Valley, who pulled together all the improvement teams from across the 3 trusts and shared lots of great practice. We had some external speakers, and also in parallel to that, we did some QSA online training for individuals. So that went really, really well, and there will be another one next year. And then also another thing that we'll see repeated next year was the Group Nursing and Midwifery Care Excellence Conference. And I say in my report that I dreamed of that kind of thing happening when we pulled together the group, which is just those kind of sharing of best practice, hearing some fantastic stories about some of the things that our nursing and midwifery teams have been doing and learning from each other. I then refer to going further to reduce outpatient waiting times. We talked a little bit about this morning at a workshop, but and we've got a call with Tim Briggs and his team at 5 o'clock this evening to look at how we're doing that as a group. So the group's been invited to take part in this exercise to go faster on reducing the backlog of patients on the waiting list. So we're looking forward to using some of the learning from some of the national GERFT work, but also some of the best practice and those other trusts as part of that project. I refer to the National Urgent Emergency Care Recovery Plan, where I'm leading on one of the work streams of that, the in-hospital process element. And this is really core to ensuring that we achieve good flow within hospitals, as well as some of the other things that are in that programme. And I really look forward to looking at some of the examples elsewhere of good practice and trying to ensure that we get the best out of things like SDEC, frailty assessment, and that patients don't spend any longer in hospital than they absolutely need to. Association of Groups update is appended at Appendix A. Good work going on there. Thanks to Sarah for producing an update on the NHS provider licence, which I won't go through, but that is now formally introduced in the way that we anticipated. There's then an update from the Women's and Children's Directorate. The headline key issue there is some new consultant appointments, which we're really pleased to see, particularly in paediatrics, which has been a bit of a challenge for us. So that's great news. We're also awaiting a CQC inspection of maternity. It's not that long ago that they came to look at our maternity service, but they are doing a review of every single maternity unit in the country as part of the response to Ockenden. So we'll be ready for that when it arrives, which will be literally any day now. More from our great teams, nursing associates. So an update on what's going on there, particularly within theatres. And I'll steal Robin's thunder, but it's really great to see this week's update at the Regional Elective Recovery Board about how well we're doing on theatre productivity. We're topping the charts at the moment in the Midlands. So thanks to Robin and everyone for their work on that. And then at the back, there's a list of visits of execs and non-execs. So I'm happy to take any questions on that, Chairman.
No, very helpful. Thank you, Glenn. Good summary. Any questions or perspectives to Glenn? Julie.
Thanks, Glenn. I really like your report. Real focus on transformation that we've had today, this morning's discussions, that improvements in performance and peppered throughout your report as well. We talk, and it's really important to know that about meeting national targets is about improving the patient experience and the patient offer. It's that absolute link. I just wondered, and I don't know whether to mention it now or when we get to the performance report, is there are some very key, but not that many specific national targets that we're aiming to hit. I just wonder if your report each time could make a reference to that, or whether it's going to be at the front of the performance report. It's just so that we keep a real focus on how we're actually progressing and delivering against them.
Yeah, I'll talk to Catherine and team about that. It might be logical to just headline it in the performance report, but I mean, one of the things I liked about the change to the soft metrics that I referred to earlier is we're looking at how long people wait. It doesn't actually matter how much activity you're doing, it's how long people are waiting for access to services, which is the key to this. So we'll make sure we cover off those headline, very few top level priorities.
No, agreed. Thank you, Julie. And Umar?
Thank you, Glenn. That's really helpful. Just a quick question about the maternity inspection that we're going to have from the CQC, and just to get some assurance really that we've taken the learning from some of the other the areas of concern from other places and some of the reports that have come out, and whether there's anything that we could showcase as good practice that George Eliot's been doing over the time. So just a question really about that.
Yeah, thanks, Umar. I know Natalie wants to come in on this, and I'll let her in a moment. The midwifery teams actually across the three trusts in the group do work together very closely, particularly George Eliot and Swift, because of the way that we've introduced a leadership role that spans the two. Swift have had an inspection. Wye Valley have had an inspection too. So there's been learning from those two. Those seem to have gone really well. And obviously all organisations are working together on some of the learning from Ockenden. I also think it's important not to just concentrate Ockenden learning on maternity services, because there's a kind of broader risk-based, safety-based, speaking up-based messages from that we need to learn from. But Natalie, do you want to say some more on that?
I think you've covered the majority of what I was going to say, Glenn, and I know Lorraine popped on screen Umar, the only bit with regards to showcasing, absolutely, we have quite a list to be able to prepare when they do come, when I get that phone call, to show them round. Particularly, I know it's in Lorraine's report, so I won't steal her thunder on some of that, but with regards to the progress that we've made in saving babies' lives, in CNST, but also in the recognition of the fetal growth when the small babies. So we're right up there in the top 10 of the country for being able to do that. So there is a lot we can showcase, and I think we're particularly proud of the work that we do with our MVP and actually listening to our women and the families, and making sure that we do a lot of co-production in everything that we're doing going forward. So I think it does, we've got that to showcase when they arrive.
That's great. And finally, Lorraine, then we'll move on. Lorraine?
Yeah, thank you. Just to provide assurance, really. So yes, we are prepping for CQC, but that could be any day. So actually, our maternity services run every day as they should be. We're not just prepping for CQC, making sure that everything is done and ready for them. It's an ongoing process. And as Glenn said, the beauty is I've just been through CQC inspection at Swift, so I've taken some of that learning across, and we look at all the reports that come out. So lots of preparation going on.
No, as you say, Lorraine, and the board have heard me say this before, but for members of the public, the two most important things we do as a trust are to bring life safely into the world and to allow life to leave the world with dignity and respect. And so our maternity services are disproportionately important. And as you say, Lorraine, but it's day in, day out, hour by hour. We know the babies are coming. We're not sure when they're arriving, but we want to ensure when that happy moment arrives that it's safe and a good experience for everyone involved. Thank you, Mark. We'll move on then to the annual objectives end of year progress assessment. Jenny, what would you like to pull out of this bit of the pack?
Thank you. Ooh, thank you, Russell. Trying to get off mute. So yes, this is a reflection on some of the activities that's taken place throughout the year to achieve and deliver on last year's annual objectives. Usually we play you a animation video. We still have the animation video. Hope some of you have had the opportunity to click onto that from the link that was provided, but we are going to showcase that at the annual general report as well. But this year we had so many wonderful things that people had taken forward under each of our themed headings that we actually decided to create this yearbook. So we hope you've enjoyed looking at the yearbook, and the intention is that this will be used to support with things like recruitment, with things like our local place partners, and with other stakeholders, to just really showcase some of the work that's been undertaken in taking our objectives forward. So we now have the yearbook and the animation video. That's all I wanted to say. Thank you.
That's great. Thank you, Jenny. Before we know, we're going to have an avatar of Glenn and Catherine and all of the board in some animated form. Any questions or perspectives to Jenny on the end of year assessment? I think overall, 22-23, another really tough year for the whole of the NHS, but I am delighted with the performance of the George Eliot. And the thing that pleases me, and we'll touch on it in a second with Hack on the planning update, is the foundations that we laid down last year are being built on this year with the business cases for the new wards, and therefore as we end this calendar year, we should be in a very strong position to drive performance into 24-25. If there are no hands raised, then I will move on to Hack and say, in terms of the planning update, Hack, we had a very good comprehensive discussion yesterday, this morning rather. Thank you for your hard work over the last number of weeks and months in putting this all together. What would you care to pull out?
Jenny's going to lead off on this paper. She's kind of led on the planning, will contribute, but Jenny has led on the planning, so she's going to lead up on this paper, and I'll chip in as we go along.
Okay, fine, thank you.
Thank you. So to be honest, I'll just pull out some key headlines because obviously take the paper as read. But basically what the paper does set out is the key requirements for delivering the ask from NHS England. We've obviously had delegated responsibility from a planning perspective to take this forward, and this document really captures the work that's been done through the submission that has gone forward and sets the position for the organisation. What the paper sets out are those key areas of target for delivery, and it clearly focuses on what we need to be delivering in terms of elected recovery and the challenges that we have in terms of achieving that greater activity in terms of the 118%. It then goes on to indicate what some of the financial challenges are, which I'll leave Hack to pick up. It also sets out the assumptions on which that we've undertaken the planning in some detail, so you can see the assumptions that have underlined the activity profiling and the financial assumptions that Hack will then take you through. But essentially this culminates in the submission that we have already put through following the delegated authority that was given by the board and is here for endorsement of that original delegation. I'll hand over to Hack for anything from the financial piece.
Thank you, Jenny. So the plan is focused on doing the right thing for our patients and our workforce, and the money effectively follows on from that. We have submitted a break-even financial plan. There's a very significant CPIP challenge, so it is something that requires a challenging level of financial improvement. But we have some big opportunities in terms of our opportunity to improve our productivity, particularly through our theatres and through outpatients, but also in terms of reducing the amount of money we're spending on agency staffing as well. And those opportunities, we've got improvement programs that have been running for some time that will support the delivery of those opportunities. So we're not at a standing start. We're building on things that we've already done, like you just said, Chair. It is a challenge, but actually I think we're well placed to rise to that challenge. We've also have been able to make a number of investments that will also support the delivery of those operational targets, but also improvements in patient experience and which ultimately deliver the money. Particularly and most notably, you mentioned already the additional 60 beds. We've also will be expanding our virtual ward offer and also expanding a frailty service. And we've got the phase 2 of CDC, the Community Diagnostic Centre, which will be opening later in the year. So some significant investments that will support the delivery of the planning targets, but also improvements in patient experience and patient care as well. And they'll all contribute to the financial challenge. So it's building on everything that we've done over the last year or so. But we will require, and we are making a change in a shift in gear rather than a change in direction, I think is kind of how I would describe it. And we are certainly upping the pace in delivery on some of those things. I'll leave it there and take any comments or questions.
Thank you, Hack. Thank you, Jenny. Any questions or perspectives from colleagues? Julie?
Thanks very much, Hack. And we have had a lot of discussion around this today, and I know that there's been a huge amount of work to get to this point of working with system partners as well. I've read this, though, slightly differently in the public report from a patient perspective. And for me, there are still some very long waits here for people that are waiting. So there were two things for me, was just around assurance about how we are communicating for people who are still waiting some significant time, and how we assess risk of harm, but also the role of GPs during that particular time of waiting. And finally, there's a very, very big financial ask here, and we've gone through this in great detail, but assurance for our public around how whether the significant financial savings are going to lead to further detriment of services for our patients.
Thanks, Julie. Catherine, do you want to go first on Julie's first question?
Well, I'll try with the last question to start off with and work backwards. So I think what I would say to the public is that whilst there's a big cost improvement to be made here, or a big financial number, when you look at the things that deliver that, that's about things that actually improve patient care. So the ability to treat patients who've been waiting a long time on a waiting list, the importance of having substantive staff in place rather than relying on temporary or agency staff. So these activities that are delivering the financial plan are actually crucially fundamental to delivering high quality, excellent care. And that's why we've been a bit more ambitious in our plan around the increased requirement over elective delivery compared to what the national plan is asking for in terms of 104% of activity. So that's the first part, is I think we could say that absolutely certainly these are the right things to do for patient care. The second point, I don't know if Jenny was going to answer the first point, but in terms of the discussion about how we're communicating with patients, we've been doing a lot of work through some of our volunteers and the work around patients on the waiting list in order to communicate with them that these patients are not forgotten, but to make sure that they are either, if there are deterioration in their symptoms, that that's brought to our attention so that we can see them sooner, but also so that we're making sure that patients are waiting well whilst they're waiting for treatment and know where they are. And that has a benefit to colleagues in primary care, that we're not expecting people to go back to their GP. We are trying to make sure that we're having that communication with them so patients know where they are whilst they're waiting for treatment.
I think just building on what Catherine said, what we do know that the greatest anxiety to patients are those often with cancer. And so working with systems colleagues to make sure that's a seamless pathway is disproportionately important, I think. And Glenn, then we'll move on because we're just running a couple of minutes late.
I was going to say a rather related point about how good this morning was, that we saw the interconnection between all of the execs actually on doing the right thing for patients that delivers the right results financially. And there's probably just a bit of question here for Robin, that obviously key to all of this is ensuring that the urgent care demand is managed and patients are managed in the right part of the hospital with the right teams to look after them. Our escalation plans going into the winter, when might we see I know it's just the start of the summer, but we do need to think about what those escalation plans are and making sure we continue with the disciplines of Operation Ring Fence that we did last year.
Robin?
Yes, thank you. Thanks, Glenn. Thanks, Chair. We've done an awful lot of work on winter planning already, and particularly from a place-based approach. So through the Health and Social Care Board for Warwickshire North Place, which I chair, in March we received presentations from all partner organisations, and we looked at what was delivered last winter and the feedback from the teams themselves on what worked well, and with a view of looking at how we then use that to start the basis of a place-based winter plan going forward for next year. Historically, it's always been worked in silos in individual organisations, and often we find when it comes to delivery late in the day, funding's allocated late in the day often, and we realise that a lot of the time that some of the actions taken by individual organisations aren't as congruent as they could be. But following the place-based approach we've talked about, we are finding much more alignment between the actions already being talked about. I did a presentation supported with Jenny's team and the coordination cell team, who'd synthesised all of the presentations from system partners, and I've presented that to the Place Executive Board earlier this month, which was extremely well received, and that has again all partners from across Place represented. So there's a lot of input already. We're already at the stage where we're formulating the first draft of our winter plan, and also heard assurance around early sightings of the financial envelopes available across the system. So how does that link in with the system-wide plan? Not forgetting that Place sits as part of the system. We're also then linking through with the system winter planning event, which is scheduled for later this month. And we're taking those plans to that event to understand how all that aligns.
Thanks, Robin. And Catherine's popped into the chat box a great meeting that occurred last week at Warwickshire North Place on that very matter. Okay, team, we're running about 5 minutes late, so if we can just try and pick up the pace, that would be great. And that segues quite nicely into the Warwickshire North Place Delivery Group Progress Report. Jenny, and I don't think we've got Selma on the line, but Jenny, over to you.
Yeah, thank you. So the first thing you'll notice as board members this time, having received these reports before, is that we've tried something a little different with this report, partly on the feedback to try and make it a little bit easier to navigate and be succinct in its focus, while still giving a flavour of the work that's being undertaken and the overview. So what we've done with the report this time is we've pulled out one of the key sort of stories of Place for this particular reporting period, and we've focused on reporting that particular element, and then we've given the overall of the status of the overall programme, and then we've given some of the highlights that have specifically been delivered in that particular month. The full report is still available for people that want the detail. So firstly, hope that new style is useful and that meets your requirements. So the key thing to pull out this time is that we've been on a journey for the last 12 months of bringing together our health and wellbeing priorities in Warwickshire North and our health priorities that have been going through the Warwickshire North executive group, and we now have a fully integrated plan, and we have those clear areas of focus, and what we've been able to do through that is really wire together some of the conversations that we've been having with broader partners, so that we are really genuinely now looking at health and wider determinants of health and partnership collaboration and the delivering on our priorities. And that's the key message really I want to leave you with today, noting that the report in Appendix 1 gives the status of the specific work streams that sit underneath that programme, which you can see are still progressing. Generally, we have one item that is a risk which we have got some plans to address with colleagues in the ICB.
Thank you, Jenny. Any questions or perspectives on the progress report? Sarah?
Just a brief perspective really to say thank you. It's really good to see this being brought to our trust board, the integral part that the trust play in that wider integrated piece across Place, and some things there that are seemingly a little distant from our day-to-day work, such as the dementia diagnosis and the SMI health checks, but actually have a huge impact on our work and also a really large impact on the wider population. So thank you for the way you've presented the report and for the work that goes on by the trust in the wider Place.
Yeah, no, absolutely. There's no question, Sarah, unless we work at Place and work on prevention and working with our communities to help people eat less, move more, be less lonely, the inevitable consequence is an inexorable and uncopable increase in demand into the acutes. Okay, thank you, Jenny, for your hard work. Keep us briefed and that progresses. And Rachel, lovely that you could join us. Rachel Dant has joined us, who's Chief Transformation Officer for the ICB, and the Health and Care Delivery Plan for the next 5 years or so is in draft form. Rachel, what would you like to pull out or particularly emphasise? Obviously, we've had the opportunity to look at it as it currently stands.
Yeah, thanks, Russell. So I will take the paper as well and just pick some key points as you say out. So the national requirement for us as an ICB to pull a 5-year plan together. This builds on the work that the system did, and your organisation were obviously involved in that throughout the autumn and the winter when we pulled the integrated care strategy together. Which was done with over 1,000 people in terms of being engaged in that from our communities, our stakeholders, and our public. That plan, the integrated care strategy, identified 3 big strategic priorities for the system and 9 areas of focus. And this delivery plan responds to that, as Russell says, from a health and care point of view, and needs to be then sat alongside the health and wellbeing strategies for Warwickshire and Coventry. So if you look at the King's Fund model of population health, this responds to the bottom left-hand quadrant, and the health and wellbeing strategies will respond to the other 3 elements in terms of the overarching delivery. It also responds to the national priorities that the NHS are required to do on an annual basis. And as Russell's pointed out, although it's a 5-year plan, we've tended to focus on the first 2 years in terms of the detail, which sits within the bulk of the plan, which is section 2 and section 3. We have submitted in the paper, you will have the link to the plan that sits on the website. And the purpose of bringing this today is we are in a process of engagement with all organisations, all partners, to look for feedback, comment, etc. with regards to the plan. Most of it is now uploaded. There's a little bit more that will go on onto the website at the back end of this week. And then we'll be looking to take it through the ICB board on the 21st of June for final sign-off, with a national publication date of the 30th of June. It is an iterative process. It has been through a number of iterations, and there is a heavy link to place in the way that you were describing earlier in terms of some of the plans, and there is a section on place. So the Warwickshire North section is within that. You'll be able to see. We have consulted with lots of committees, collaboratives, and the places themselves in order to co-produce this. 2 common themes have already started to be gathered in terms of the work we've been doing, very much around deliverability. So this is a very ambitious plan. When you see it in its entirety, it's quite a lot to be able to do, recognising that we've either signed up to doing this nationally as part of the planning guidance, or that organisations, partners wish to do these things. And then there's still further work to do on the governance that wraps around this to make sure that the board are cited on the progress, and that we've got success measures that sit alongside the integrated care strategy so that they dovetail together. So that was all I was wanting to say, Russell, here, just to invite people to comment, either take questions today, pass on any feedback, or, as I say, you've probably got another fortnight to actually submit comments to us, but welcome the opportunity to engage with the board.
No, thank you, Rachel, and thank you for your hard work and your team's hard work behind the scenes. I'm sure on occasion it's been like herding cats, getting everyone involved to give their view and to try and join it all up. Questions and perspectives. Julie?
Thanks very much, Russell. I guess one's seeking assurance, which I know this is the case, but from a public perspective, that this ambitious plan is fully aligned to individual, for us in terms of the group and individual trust objectives. So seeking assurance around that. And the other one then is about reporting delivery in terms of how that will be reported at the ICB, but how that gets back into individual provider boards.
Yeah, thanks, Julie. So the first thing is, obviously we've done the work, and Jenny's been heavily involved in this. So she's been actively involved in actually helping us produce this plan as part of the strategy planning group. So this has been done with place in mind, and from an organisational perspective, there will be alignment around the priorities that sit within the overarching strategy. I don't know whether, as an organisation, you've done any work to map the priorities. We certainly have done that with place, but we haven't done it through an organisation. But Jenny might want to comment on that. I would hope that they sit alongside the priorities that you would want to deliver anyway as an organisation. I can't imagine that they wouldn't. And then in terms of the reporting, you're absolutely right. This is quite a spider web diagram of all the different groups that are going to own elements of this plan. And that's why there's a task and finish group that's been set up to try and map that, but very much committed to try and embed this within our existing governance structure, so we aren't creating another layer of governance. And as part of that, that will obviously go through the board, the ICB board, and therefore I'm absolutely sure that the reporting of that to the board can definitely be shared with you as an organisation on a regular basis.
Thank you, Rachel. And Glenn?
Yeah, I also wanted to thank Rachel for her work on this. As you say, it could have been a challenge to herd us, but consider this cat herded on this issue, because it is a good strategy. It does align to the strategy across the group, because that's based on population health model also. And I like the place focus. I like the ground up focus on primary care networks, particularly around population health management and using the data that we have. So I think it demonstrates what we should be focusing on as an integrated care system, using the combined strength of all of the parties to it. So absolutely aligned to it.
Thanks, Glenn.
And I think the only observation I'd make, Rachel, would be, as you've heard me say in the past, for me, the future is prevention and primary care rather than expensive acute care. And so just making sure over time that the funding recognises that and acutes cut their cloth accordingly, I think is very important. Rachel, thank you. We'll do all have the opportunity to further input if you'd like to, but in the meantime, take care and carry on with the great work. Thank you.
Thank you very much.
And we've been talking about place, so that segues nicely into the levelling up update. Jenny, anything you particularly like to pull out on this?
So I suppose really it does link really well with the conversations that we've just already had. So I suppose the main point I would want to raise is that we have worked with the Purpose Coalition to look at the work that's going on through Place Partners around this agenda and levelling up, and particularly links into our health inequalities theme. It was very much a collaboration with our Place Partners, and I hope that's reflected in the report in terms of capturing the various different programmes of work that are taking forward and the way we continue to work together as partners. And the other key message is that this report will now go forward and be part of the delivery for Place as part of that programme. So it's not sitting outside of that, it's very much linked into that work programme. And also as part of that, it links into each of the boroughs' levelling up plans. So it's very integrated, but it just pulls out the kind of focus for our place in under those goals.
Thank you, Jenny. Any questions or perspectives on the levelling up report? On any digital hands. Just one from me, Jenny. When we discussed this at Swift, I commented that I didn't really like the phrase levelling up. I know it's the phrase that's commonly used. And we did talk about something like equality for all, but something that felt more positive than levelling up. And it sounds as though we run a carpentry or a building firm. So can I just ask you to have a chat with the Swift team and just see if we can't adjust the language just to make it a bit more in line with some of the other narrative we use. But levelling up for me does sound as though I've got a problem with a shelf, which I often do have problems with shelves, as any of you who have seen my DIY efforts will testify. Colleagues, happy to move on? So Kirsty, welcome, and thank you for the Q4 estates report. What would you care to pull out?
Just a couple of things really, Russell. So for those of you who've been to site, the Community Diagnostic Centre Phase 2 is well underway. We've got a building there. And we're looking now to pull together a business case for Phase 3, which will look to move breast care services above the MRI and CT scanner area, which is just white space at the moment. Some really good news is we've received funding as well for 2 new 30-bedded modular wards, so they'll be very welcome. The 2 wards not only will give us some additional capacity during the busy winter period, it'll also support the delivery of the 92% bed occupancy and improvements in flow and efficiency, but it will also help us during the less busy periods to refurbish our existing estate and undertake deep cleans. So that's very welcome addition. On not so good news, unfortunately, we did receive a confirmation email from the Department of Health that we haven't been successful with our expression of interest for the maternity building. So there are 7 hospitals nationally that have been successful. They literally do need rebuilding, so that funding has been allocated to them. But they've strongly encouraged us to pursue this bid now through the ICS and normal capital. And then just to say on a good note as well, we've completed the works to our day procedures units. Theatres A and B were completed on time and on budget, and it's a really nice environment now, not only for our patients but our staff. So that's welcome news for that. Estate strategy, we're hoping to see the first draft on the 15th of June. It'll be reviewed by the estates operational group, and then that will be hopefully going to TMB towards the end of June and the beginning of July. And they're the main bits from the report really that I wanted to bring to the board today. Any questions?
Thank you, Kirsty. And can you pass on our thanks to all of your team for the really hard work that's going on behind the scenes? It's great that we're laying down such important capital to increase our capacity and our services for patients. Questions and perspectives, Anil?
Thank you, Chair. Kirsty, firstly, thank you very much. I know you and your team are supporting some of the work initiated by the charity to improve patient experience. One of the areas your teams are supporting on is installation of TVs in the wards. Are you able to share with us the progress on that?
Yep, we did a deep clean of AMU, which included a little bit of refurbishment, and we took the opportunity to install the TVs within that area. So all the enabling is done, and I've been told this morning that the TVs have arrived for there. During the next stage is Drayton Ward, and they'll get the benefit of the TVs as well. So as we get areas to refurbish and deep clean, those TVs are going in. So they'll not only support the charity, but also we're hoping health promotion advice will go on there, and also our electronic menu system, which will improve things for patients in terms of food and nutrition. So, okay.
Excellent. Thank you to you and your team for your support.
You're welcome.
Thank you, Kirsty. Julie?
Hi, Kirsty. Very big thank you, same as everybody else. Good to see you. I don't think I could have envisaged such significant change over the years that I've been with Georgia. It looks completely different. I just wanted, we've heard today about significant outcomes that we're looking for, targets that we're going to achieve. And I was just wondering about how any disruption is going to be managed in order to make sure that we don't impact on those.
Is this just in terms of the new wards and the delivery of them? Yeah, so we'll be working with the ops team. We've already spoken with Wernix about limiting that disruption to the Captain Tom Ward unit and the theatres, and they're just working with us now to develop a programme. So obviously you can't crane over a live area, so we'll be working with the ops team about how we can move the activity. And obviously it's they're due to be delivered. It was July, but they're looking to bring it forward a little bit now, which is hopefully, and I'm touching a bit of wood here, a less busy period, so that we can actually empty those areas and do one side at a time. So that's the plan.
Thanks, Kirsty. Thanks, Julie. And finally, Glenn, then we'll move on.
Thanks, Kirsty. There's clearly a lot going on. One of the things that I thought I'd see in here but isn't, though, is the carbon reduction work. And can you confirm we are still looking at putting a Salix bid in later in the year, because that's obviously one of our big moves?
Yeah, so the decarbonisation plan went to TMB at the end of April and was approved. It kind of sits between the two, this one. It tends to be more in the sustainability update report rather than the estates update report. But part of the estates strategy is that decarbonisation plan, and we are still online for September to get our bid ready to go in. We've also put a bid in for the low skills fund as well, to try and secure funding for actually putting those bids together. So we hear this month, I believe, if we've been successful with that. So yeah.
Okay, super. Kirsty, keep up the good work. That carbon reduction work is disproportionately important. Remember Councillor Caldercott's idea about putting lots of solar panels around. I'm still waiting for a full update on that. But in the meantime, take care, put your builder's hat on, and get the shovel out, and let's carry on building. We'll move on then to quality part of our report. And the first is the safe nursing and midwifery staffing. Natalie, what would you care to emphasise in your report?
Thank you, Chair. As usual, we'll take the paper as read, and there's a lot of detail within the paper, but the areas that I'd like to bring to the board's attention is to highlight the progress really with the recruitment. We've all heard today through our workshop the attention we're paying on recruitment and retention particularly, but I'd like to highlight our healthcare support workers. This group are difficult nationally to maintain and retain within healthcare. So we've been working very hard on both local and national programmes with our frontline teams, and to ensure that we are getting that right. And I'm really delighted to say, if you look at our vacancy rate, although I will always want it lower, that has reduced from about 18-19% a couple of months ago to just over 11% for that group of staff. And we're obviously working hard on our other group of staff, which are most important at the moment because of the vacancy rate, is with our registered nurses. So with regards to those, we've just welcomed our 5th cohort of international nurses into the organisation, and we have signed up to the extra support being offered by NHS England to increase the number of international nurses that we receive into the organisation. So we're aiming to have 110 nurses with us by the end of the year. Obviously, they'll be through various stages of their training. And so far, out of the 3 cohorts that have gone through their OSCE training, I'm pleased to say that 21 of the 30 have passed their OSCE examinations. 11 of those have already received their NMC registration, and we are supporting the 9 who have failed on one of the stations in the first go round to achieve their OSCE the next time, and their resits are already booked. We're making really steady progress on reducing the amount of temporary staffing that we're using. We are all absolutely committed to having our own permanent staff, being able to develop those staff, because we know that will deliver the quality and safe care that we are driving forward. So we have been reducing the agency spend in the first instance, and then we will look at the bank spend, and we have been able to progress and shorten the period that those shifts are open to the agencies, and to remove some of the high tier agencies from our list. But whilst doing that, we're maintaining and keeping a very close eye on quality and safety. And you will notice in the report that 27 incidents have been raised with regards to staffing levels. But I am pleased to say that when we look at all of those in close detail, there is no harm related to patients, and all areas are mitigated through the daily updates of both nursing and maternity, looking at our staff cascade across the organisation.
Super, thank you, Natalie, and thank you for that assurance. Questions and perspective, Umar?
Thank you, Natalie. That's really helpful and really great to hear that we've got our recruitment numbers up, especially on international recruitment. Just a quick question on the international recruitment and the recruits we've got. What plans have we got in place for integration and support? Because the last thing we want to do is invest so much money, energy, but more importantly, the individuals who are coming into George Eliot, to make sure that we retain them. Because, you know, I have had experience in other NHS organisations where there's been quite a big exodus of international staff because they just couldn't settle or there was real challenges. So just some assurance really around what we're going to do with that, because we need to make sure that obviously we're getting return on investment, but also making sure our staff are feeling part of the culture and part of the organisation.
Thanks, Umar. Natalie?
Absolutely, Umar, it's one of the key points, as you can imagine, and I could spend the next 10-15 minutes going through what we've got, but I won't in matter of time. We do have pastoral support, so we have just agreed a position to put in a specific member of staff for that pastoral care. Through the education and practice development team, we have what's typically known as an onboarding induction program, and what we've been doing with each of the cohorts is going back to them at the end of the session to say what worked, what didn't work, what else do we need to put in, and particularly on things like language that we think is simple and understandable is very different, and making sure that we've got all of that right in their support going through. And we'll be keeping a very close eye on the attrition rate with regards to international recruits. The one thing that we talked about this morning was progression and development. And I'm very keen to make sure that we have equity throughout with that, because we recognise that particularly for our international nurses, sometimes that progression and development isn't as fast, or there's not the opportunities. So we also have one of our heads of nursing who is involved in the regional work for the BME and inequalities work, so she is bringing that back to nursing and midwifery on a quarterly basis, making sure that we've got an inclusivity.
Thanks, Natalie. Thanks, Umar. We are running about 10 minutes late, guys, so if we can keep our questions short and use the chat box if possible. Rosie?
Okay, thank you. Thank you for the report. So much work goes into this area, but I wanted to comment on the fact that this is a report for AHPs as well. And although AHP vacancy rates are only at 15%, that's still 15%. And so I wondered whether you could share a little bit about how AHP leadership feeds into this report. It does provide details that there's no physio and OT vacancies once we're recruiting our next round, but does that mean we're okay with speech and language therapy, dietitians? There's about 14 AHP professions, isn't there?
There are.
Some organisations have AHP leads. So I'm not expecting a full answer here. We haven't got a lot of time, but it's just really a bit of assurance that we are confident that we employ enough AHPs, because they have a big impact on deconditioning, discharge, and a slightly different philosophy of practice as well. So that's really just an observation and a comment, and perhaps we don't have time to discuss it, but
I'm very happy to take offline with you, Rosie, about what we're doing. We do have an AHP lead, and we meet regularly. Yes.
Natalie, just can we minute the point, Rosie? And in the minute on the action log, can you just sort of detail things more comprehensively, Natalie? Thank you. And Julie?
Sorry, just very quickly, just very big thank you, Natalie, for the report. Very honest and open discussion within it. I've noted that we're at the lower level of national average about care hours, and I just wondered what that actually means for patient in terms of patient experience and how we're mitigating risk of harm there. It was good to hear about how your arrangements actually do you got assurance around harm, but just that care hours per patient.
Yes, it is something, Julie, that we monitor very closely, because we are at the lower quartile, and that's why looking at the incidents and making sure that there's no harm related with regards to staffing elements. But again, and we take that through the Quality Assurance Committee as well, and through the Nursing and Midwifery Forum.
Okay, thanks, Julie. Thanks, Natalie. Sarah's just dropped something into the chat box. And thank you, Rosie, for clarifying your key questions. That's great. Lots of work going on, still lots to do, but we're making great progress. Thank you. We'll move on then to the maternity assurance update. Natalie, is Lorraine going to lead on this? Lorraine.
Hello and good afternoon, everyone. Thank you. So I'll take the report as read, conscious of time, so I'm just going to pick a few highlights out. This is an update from April 23. So we had 62 Datex incidents reported in month, which was down slightly from the previous month. We had no neonatal or maternal deaths or SI declared, serious incidents declared. Sadly, we had one stillbirth at 25 weeks, so we're just going through the learning from that and supporting family and staff involved in that. But just say on our rates of stillbirth still remain below the national average, so we're at 2.32. Our midwife to birth ratio is at 1 to 27, and all our women received 100% of one-to-one care in labour. Our training rates for prompt were up in month, which was really pleasing to see. Really also pleasing to see is our Saving Baby's Life care bundle compliance. So we've gone from 53% in August to 88% in Q4, and now fully compliant in 3 out of 5. Although we're not going to sit on our laurels because version 3 has been released this week, and we know there's an extra element, an element 6, which is around diabetes, pre-diabetic care. So we're just working through that now. We also know that CNST Year 5 was released also this last week. So just working through what that means going forward, as well as looking at the gap analysis for the single delivery plan. Our vacancy rates, as Natalie said, is really good in maternity, and we've just recruited some newly qualified midwives who will start in October. And at this point in time, that will mean our vacancy rate will be 0, but obviously we know that's an ongoing progress. But compared nationally, that's really good to see. Our sickness rates were slightly down in month as well. Lots going on in maternity, as you've heard, around our estate. So we've got our theatre refurbishment in progress. So Theatre 2 has been pushed back slightly, and that'll be due for completion in August, and Theatre 1 for October. We're starting some work on refurbishing Drayton Ward, which is our antenatal and postnatal ward, and that the electric works have just started, but actual work actually on the ward will start in the next few weeks, which is really pleasing to see. We're also working with our MVP to look at our League of Friends cafe. So colours have chosen, name is just being decided, and work is starting with that, and that will be open soon. So hopefully July we're hoping, and that will be really good to see. We've mentioned CQC imminent visit, so happy to take any questions.
Really comprehensive summary, Lorraine. Thank you. Any questions or perspectives for Lorraine? 2 points for me. Our heart as a board goes out to any parents who have lost a loved baby, and you're in our thoughts. On a more positive note, a 1 to 27 ratio is fantastic, Lorraine, for midwives to birth, so well done on that. We'll move on then to less sort of optimistic things, mortality and learning from deaths, Q4 report. Naj, what would you care to pull out of your report, my friend?
Thanks, Russell. So I'll take the report as read. I'll just a couple of highlights from it. Starting with the data. So SHME, we remain within expected range, and we've been so within the last almost 3 years. HSMR, we are still outlier, but you know the figures are showing that there's a gradual improvement with those with the HSMR as well. Couple of conditions where we have been flagged as outliers and work has been done. Very briefly, fracture neck of femur, and that's sort of come on the radar in a couple of areas, HSMR, SHME, and the fracture neck of femur national database. But we turned to our teams as usual, and they've done a lot of good work, unpicked what the problems are, put in some sort of action plans, which in this particular case for the fracture neck of femur were around some data quality input and also delaying getting patients to theatre, which is really important. We need to get our patients with fracture neck of femur within 36 hours to theatre. And we've seen immediate results. So we're now, according to the National Hip Fracture Database, which is the most up-to-date sort of measure, we're now at national average. So that's good news there. The other condition was septicemia. Again, we've seen some, we've been flagged as an outlier of septicemia. Again, we formed a task and finish group, multidisciplinary. They've formed an action plan and made some recommendations already. So a lot of, and because this crosses the whole organisation, I say it is important that we got the right group working that, and already they're starting to do quite a bit of work. So those were the two sort of outline conditions I wanted to mention. And then in terms of learning from deaths, Just to mention that our medical examiners, which include GPs now, as well as hospital consultants, continue to review the vast majority of deaths in the hospital, 98% in Q4. In parallel to that, there are also structured judgment reviews with certain types of death, one of which was a learning disability death, which we learned quite a lot from. It was deemed as poor care. And as a result of that, we've set up a working group to look at this particular group of patients that we get admitted. And again, multidisciplinary working, not just within the organisation, actually. We've taken a system response. So we've got colleagues from the ICB also helping us out, as well as, I say, Learning Disability Acute Liaison Team. And again, already they've put into place quite a few actions and a lot of education around patients who are admitted with learning disability, such as highlighting them when they're admitted so the acute liaison team can get involved in their care early on, act as advocates for them wherever necessary, advise on funding that may be available to support the patients while they're with us. So that's another piece of work that, as I say, is already in place. So those were the sort of main highlights. Happy to take any questions.
Thank you, Naj. Any questions or perspectives to Naj? Naj, can I just ask you on that learning disabilities learning, to take that up with your CMO colleagues elsewhere in the foundation group, because there must be shared experiences and shared learnings, and I just want to make sure you're identifying the best way to look after those patients and learn from one another. So if you could take that forward, thank you.
Will do, Russell, thank you.
Okay, we'll move on then to trust-wide incidents Q4 report. Again, we'll take as read. Naj, anything you particularly like to highlight?
Yeah, so again, just a couple of areas. So we have a very good reporting culture here. Again, you'll see that we do encourage reporting, and most of them are 98% are low, no harm. Where there is moderate or serious, undergoes more sort of structured review in this under the serious incident framework. Perhaps just to highlight the great work done in the directorates to reduce the number of open incidents. So you can see from Q3 to Q4, a reduction of 527 to 351. And the biggest FURA there for medicine, obviously biggest directorate, biggest number of incidents, and they've really done a big push to reduce theirs from 286 to 171. So great news on from them. And then perhaps just to touch on this transition that we're going through from serious incident framework that's we've been using to the new PSIRF, so that's Patient Safety Incident Response Framework. And we've just gone through the first cohort of training. Myself and Natalie were honoured to be on that. We just finished last week. And it is definitely a different way of approaching incidents. There's more learning involved, more human factors involved. There's tools that we can use to actually, use from the time of the incident through to the final improvement plan. We don't use the word action plan anymore. So it is a new way of learning from incidents. And I think we're all quite excited about the change. It's just now about, as I say, sharing it across the organisation and embedding it over the next few months. We're due to go live in the autumn time. So happy to take any questions.
Thanks, Naj. Any questions or perspectives to Naj on that? Naj, does using the PSIRF system, does it take longer than the old serious incident?
So I think to start with it will, because it's going to take us a little bit of time. But I think once we get used to it actually and get used to the tools that PSIRF introduces, I think it sort of streamlines it and makes it more it's more user friendly. And what's more important actually, it's a more clear way of sharing that learning and embedding the learning within the organisation.
That sounds like a reason to be cheerful to me, Naj. Thanks for your hard work. Doing a great work for us. We'll move on then to the Health and Wellbeing Biannual Report, which again we'll take as read. But so, anything you particularly want to pull out?
No, so the report outlines the achievements of the Health and Wellbeing team over the past year on the delivery of their 6 core priorities. I think it's important to note that the team not only signpost staff who are in need, but they also do a lot in the way of education and supporting staff in their own self-care choices. So it's about as much about health promotion and ill health prevention as it is about responding to health needs. We're also in the fortunate position that our head of wellbeing is the chair of the Coventry and Warwickshire Health and Wellbeing subgroup and sits on the People Board. So it is an area where we work really closely across the ICS on our staff wellbeing, not only within NHS Trust, but actually with our place partners as well. So for the coming year, they've identified 4 areas of focus, which are expenditure, so using the health and wellbeing funds most wisely, engagement, so promoting the role of the health and wellbeing team and having health and wellbeing champions in each area, evaluation to understand what is most beneficial to staff, and engaging in some research with Warwick Medical School to look at how flexible working supports wellbeing retention, particularly of healthcare assistants, and then finally the environment, providing some outdoor exercise equipment, etc. And I think finally, just to point out, the health and wellbeing team also supports both the vaccination hub and occupational health across the organisation. Happy to take questions.
Sounds like exactly the type of stuff we should do as an anchor institution, trying to lead the way to help our staff with their health and wellbeing. Any questions or perspectives to Sarah? Okay, thank you, Sarah, and thank you for deputising today. So, day in, day out, we need to perform. Our citizens require it of us. Catherine, on the integrated performance report for April, how do you think we're doing?
All right, well, I'll go through the metrics that we've talked about, and where we're off track, I'll try and give you an indication as a board as to where the timescales I think we're talking about for improvement. So we started April with a high occupancy, 100%. We've talked quite a bit about our bed occupancy. In March, we were able to close 13 beds that we'd opened for surge capacity during the winter. But we continued to have extra patients on one of our wards, and we managed to close Katrina ward, which is 5 patients, for just 9 days out of the month. So that put a lot of pressure on flow through the hospital, and that impacts on our emergency performance. So we saw a slight improvement in the month in our 4-hour standard, which increased to 75.2%. Now that's around the national average for the month of April of 75% in terms of national performance. What we did see in April was a reduction in long delays for ambulance handovers. So that had been improving from our worst point in January. But we had 19 delays of over an hour, which is the lowest value since October, and one of the best performing for that metric nationally. We're not consistently meeting the triage times for ambulances of 15 minutes, which is the standard, but our average time is around 22 minutes from the ambulance arriving to handover. And as I say, this is an area where others come to learn from us about our performance. So overall, in the emergency target, we're starting to see improvements from the winter months. But at this point, we're about in the middle of the pack. I'm sure the coup would want me to mention that for the week ending the 4th of June, we were second best in the West Midlands for that standard and 9th best in the country. So I am forecasting that that's an area where we're going to see improvements as we go through the year, but slow and steady, and let's hope that we can continue to maintain the performance that we saw last week. In terms of elective recovery, we continue to deliver ahead of national targets, so we have no patients waiting 78 weeks or more. The national aim is to have no patients waiting 65 weeks by the end of the financial year. And we will be trying to meet that target by the end of this month. We did, as you can see from the figures, see an increase in the number of patients waiting over 52 weeks for treatment, from 95 last month to 124 this month. And that was planned because, as you've heard in various other talks, we've been doing some work on our day case theatres to improve the ventilation in those theatres to allow us to treat a wider number of patients. And those theatres are now up and running again. So that's an area that we're going to need to keep focus on, but we are trying to stay ahead of the national targets on delivery of the elective work. In terms of our diagnostic targets, so the number of patients that get their diagnostic test within 6 weeks of referral, that fell in month from 91.5% last month to 87.4%. Now, this is because we've switched some of our activity away from routine activity to prioritise urgent tests for cancer. And whilst that's the right thing to do clinically, it will have an effect on that metric. That said, again, our diagnostic performance, as Glenn said in his action update, is one of the best in the country, again, on that metric. Whilst the time for treatment, for time to have your test, is a good news story, we have experienced some delays that I'd like the board to be aware of in terms of the report for some of our radiological tests. So that's not measured in this target when the GP gets the report of the test. But this is an area that we are seeing significant improvements on, reducing that backlog, getting reports back to GPs earlier. And we will continue to track that, because it's no point having the test without having the report. Cancer is an area where we aren't meeting the standards at the moment, and this is an area where there is considerable focus going on. I anticipate that we will start to see an improvement. The target that people are measuring mainly at the moment is the faster diagnosis standard, which is within 28 days to diagnosis from referral. But the national target for that is 75%, and we were at 58% in the month of April. I anticipate that we will be on a trajectory to meet that target around late summer, July, August time is where I envisage that improving. In terms of the people metrics, you'll see that we've referenced that sickness absence is improved over the last 2 months, and its vacancy rate has now fallen from the highest level in December. Statutory and mandatory training remain good above the trust targets, but our appraisal rate has stubbornly remained lower than 85%, which is the trust target. And we talked a lot as a board this morning about the importance of supporting staff, about staff experience, and appraisals are fundamental for that, fundamental to the last paper about wellbeing. So that's something that we will continue to track through FPE with recovery actions in order to correct that position. And as we talked about this morning, our financial performance is strongly linked to everything I've just said about the operational performance. So the reduction in staff sickness and the reduction in vacancy rates and closing some of that super surge capacity in March did lead to a reduction in our temporary spends, temporary staffing costs. But from the operational plan, we did not deliver the amount of activity that we planned to do in April, which resulted in a deficit of £1.5 million in the first month, which is about £0.7 million off track. And you've heard in the board this workshop this morning about the activities that are in train in order to recover that financial element of the plan. On the quality element, you've heard from Naj about the mortality, so I won't go into that. I just want to touch on the C. difficile rate because that's an important area of focus for us. We did not meet the target last year, but there is a robust plan in place that has been developed with ICB partners in order to really try and meet that target for this year, though that is a challenging target of only 13 or fewer cases for the year. So finally, I think you can take assurance from our discussion in the morning that there are plans in place to help us in the areas where we're off track, but I think we're in the best position in order to meet the standards of care and that we aspire for our patients and the trajectories. The only thing I do want to say is that the forthcoming industrial action may impact on some of our plans, though there are robust plans in place to make sure that we can care for our patients safely during any of those periods.
Catherine, really comprehensive and granular summary. Thank you. We've obviously discussed an awful lot during the course of the day so far on what Catherine's covered. Any questions or perspectives to Catherine? Okay, Catherine and team, you're doing a great job for us. Please carry on doing it. Look forward to seeing next month's results. We'll then move on to the governance aspects of today's board meeting. Still got a lot to cover, guys. The first is the going concern update. Hack, are we a going concern?
Yeah, that's certainly the conclusion of the paper. Just to kind of give some context for year-end accounting purposes, for last year's financial accounts, the board is required to consider whether we are going concern, and also to agree the associated policy note that goes with the accounts. The paper sets out our assessment on whether we are going concern. It's been to audit committee, and audit committee has approved the paper and agrees with the conclusion of the paper that we are a going concern. The key considerations are around whether we've been asked to cease providing services without transfer to another body. And the second consideration is whether there are material uncertainties regarding our ability to continue providing those services. So the board is asked to support the conclusion that our accounts should be prepared on a going concern basis and agree the wording for the accounting policy, which is shown in blue text within the report.
Thank you, Hack. Always find it a somewhat strange context, going concern of a public body like a hospital, but there it is. Any questions on the going concern update and the wording in blue, which we need to agree to? If you're not happy to approve that statement, please could you raise a digital hand? Hack, thank you, duly approved. Thank you, audit colleagues, similarly. Then to receive and note the Data Security and Protection Toolkit submission report. I don't think we've got Ben on the line. Hack, what would you like to pull out of this?
Yeah, Ben's otherwise engaged, so I'll take this one. I'll also take the FOI paper later on. So we're required to do an annual assessment against the National Data Protection and Security Standards. So this report sets out our self-assessment against the 113 mandatory assertions. At the time of writing, we were saying that there were 2 out of the 113 that there was a risk that we might not meet those 2 out of the 113. But we have plans in place to make sure that by the end of July we are compliant. So if I just quickly flag those 2, one is about the information governance training. So 95% of staff need to have done the information governance training. As of today, we are at 92.6. So we have seen a significant improvement over the last couple of weeks. We're not a million miles away. We're hopeful we will get there. We've got really good engagement from the directorates. So we're hopeful by the end of the month, when the submission is due, we will get there on that one. So hopefully we'll only have 1 outstanding by the end of the month. By the time we do the submission, that one came to light quite late, because what happened was that Microsoft decided they were going to stop supporting some of the operating systems that we have running on some of our servers. That was quite a late notification, so we could not do what we needed to do in time for by the end of June, but we are confident it'll all be done by the end of July. So at the time of submission, we'll say we're not compliant, but we are confident by the end of July we will be saying we are compliant. So it's in terms of what are the implications of this. This is really about us being able to demonstrate that we are protecting our data, our patients' data, and our staff data. And what we can say from this is, yes, we've got good processes in place to give assurance to the board and to the public that we have the appropriate processes in place to protect staff and patient data. So the board has been asked to sign off the submission that we're making by the end of July in the action plan to make sure that those 2 final assertions are completed by the end of July.
Okay, thanks, Hack. But as I think BA, Boots and the BBC found yesterday when they came under an enormous attack, I think particularly given different conflicts in different parts of the world, we shouldn't be naive about the challenge of cybersecurity and data security at the moment. But as you say, we're doing best endeavours. Any questions or perspectives to Hack? Okay, thank you, Hack. So if you're not happy to approve that deadline at the end of July, could you please raise a digital hand? Duly approved. Thank you, Hack. So we then move on to the annual risk appetite statement for the year ahead. Claire, I think, has been involved in this. Thank you, Claire. But Natalie, anything you particularly want to emphasise?
No, thank you, Russell. It was just for the board's approval. This has been to the Executive Risk Committee and it has been through the Audit Committee. The only one thing to note that is of change from last year's risk appetite statement is the inclusion of the sustainability that you'll see towards the end of the report. So all of our risks have been aligned with the strategic objectives, I suppose it's just to say that risk is inherent in the provision of healthcare, and it's just making sure that the board are cited and where we have assessed ourselves to that level of risk and our appetite up for it.
Great, thank you. Any questions or perspectives to Natalie on the risk appetite statement? If you're not happy to approve it, could you please raise a digital hand? Duly approved. So we're then on to the board assurance framework for 7-day hospital services. Naj, back with you.
Thank you, Russell. So this is an annual report. Again, we are required to assess our 7-day clinical services every year, and this is a revised BAF. I'm pleased to say requires less data collection because the last one was really data heavy. So they've revised it, and this is what we've used for this particular report. The 10 standards stay basically the same, 4 of which have been identified as priority clinical standards, and that's based on their potential to positively affect patient outcome. And overall, you'll see from the report, actually, we do quite well against all of the standards. The one area that we probably, are working on to improve is the weekend discharges, but I think this is a national problem. However, we've been doing work on it, and some of the initiatives locally have been introduction of an enhanced medical discharge team on Sunday, this monthly multi-agency disciplinary event, which also improves discharges. And you mentioned earlier about the community recovery service, Russell, and that's certainly having an impact and paying dividends, because we're seeing our medically fit for discharge numbers come down quite significantly. So that's really positive as well. Obviously, these sort of things we'll continue to work with, and enhancing weekend discharges is, as I say, one of our priorities. But overall, I think, as you can see from the report, we do quite well, and this will be an annual report which we'll present through the Trust Board. Happy to take any questions. Thanks,
Naj. Very clear. Questions and perspectives, Glenn?
Good to see an update on this, Naj. This is going to become a bit more prominent as part of the urgent emergency care delivery plan I referenced earlier. So I think keeping an eye on that profile of discharges over the weekend will be important over this winter. So probably, whilst I accept the full report, probably come here in a year, would be good maybe to look at that, maybe in F&P through on a ward-based analysis, just to understand if there's any particular wards where we've got more of a slowing down at weekends.
Thank you. Will do. Thank you.
Thanks, Glenn. And Catherine?
Sorry, it's my eagle eyes. I think the metrics in section 5, standard 6, around what's delivered at the weekends for the stroke metrics and the PCI for heart attacks, myocardial infarction, those are probably available. Well, they are available via a network at the weekend, just they're not delivered on site here. So perhaps just note that.
Yeah, I was going to sort of make a related point to that. It is where digital, I assume, can help an awful lot on some of these MDT works where we're able to pull people in through networks and through remote working. Any other questions to Naj? So keep us brief, Naj. Don't be a stranger and wait a year. So we'll move on then to the summary of ratified policies. Catherine, anything you wanted to pull out of the summary of ratified policies?
No, there is not, Russell. This is for information. 2 were ratified in April and 1 in May. I think 1 in May.
Yeah.
2 in May. 2 in May.
So any questions on the ratified policies? Okay, thank you. Duly noted. Then we're on to the review of some terms of reference for the policy review group. Catherine?
Again, these are hardly changed at all. The only thing we've done is invite the Chief Medical Officer to join or a nominated deputy.
Naj, that's going to be the highlight for you. Any questions to Catherine on those? Okay, duly noted. Oh no, so that's for approval. If you're not happy to approve, please raise the digital hand. Okay, duly approved. Thank you. So we're then on to the summary of annual reports. The first of which is the FOI annual report. Hack, I think you said you were picking this up in Ben's absence.
Yes, I am. Yes, this annual report shows a significant increase in freedom of information requests in the last financial year, with subsequent resultant reduction in compliance with the requirement to provide responses within 20 days. We have a plan in place to improve our response rate. It's regularly reported to Audit Committee and to Trust Management Board. So I think that's all there is really to kind of draw out from that report. I'll take any comments or questions.
Questions or perspectives on the FOI report? Just one from me. If we've got an individual who puts in an awful lot of FOIs compared to a broad church of people putting in FOIs, are we picking up the difference?
It's not something we necessarily look at, but what we do look at is whether the request is unreasonable. So if it requires a huge amount of work, we will push back on it. So there are some limits set in terms of the amount of work required to respond to FOIs. But in terms of volumes, wherever they come from, we have to respond unless they meet the specific exclusion criteria.
Yeah, I appreciate that. It would just be good because I'm conscious of the fact, certainly Catherine and I think Naj, do get an awful lot of requests from one particular patient about things. It would just be good to understand whether there appears to be a small group of people asking for these FOIs or whether it's a broader church. I think the issues and the anxiety of the board would be different if it's dependent on that. I know we have legal responsibilities which we need to fulfill either way, but if you could, low priority, just come back to me on that, that would be good. Any other questions on the FOI annual report? Okay, do we have to approve that, Hack? It's not clear.
No, I think it's just to note.
Okay, super. And then the Guardian of Safe Working Hours annual report, Naj?
Yep, thanks, Russell. So again, the report provides sort of general assurance that the Trust is fulfilling its obligations regarding compliance with junior doctors' contract. So our doctors are in effect working safe hours, and they are encouraged to fill in exception reports if they happen to work overtime or miss educational training opportunities. And the table in the report shows what that looks like over the year. So there's 78 over the year, mostly in medicine, but even the medicine ones have improved. And I think those were broadly around sort of gaps in junior doctor rotas, which Winston and Co have done a great job over the sort of winter period. And you can see the numbers of exception reports in medicine have dropped significantly. And the only other area was a T&O doctor who clearly didn't know that they were meant to be filling exception reports, did it retrospectively and filled in 16 exception reports, which Mr. Frugi, our Guardian, is now busy working his way through to get some resolution. The good news is, as I say, we nip these things in the bud. There's really good relationship between the Guardian, the junior doctors through their forum, the educational clinical supervisors, the medical education, staffing, the whole lot work really closely together. Good communication, I think, is the key to it. And we've not received any fines, so that's a good sign as well. Happy to take any questions.
Great, thanks, Naj. Any questions or perspectives to Naj on the Safe Working Hours annual report? Okie dokie. So we'll move on then to the Quality Assurance Committee annual report. Natalie or Sarah?
Happy to take this one forward, Russell. Thank you. The paper just gives that assurance with regards to the workings of the Quality Assurance Committee and that self-assessment piece during the 2022-23 period. It highlights the areas of good practice and areas for improvement, which we are already working on. A number of those have already been ticked off and included in our meetings going forward. And I think just to highlight, 100% of the members agreed or strongly agreed with the effectiveness of the committee, which was really good to see, and that there was a team working ethic throughout the committee. Happy to take any further questions.
That's great, thank you, Natalie. As chair of the Quality Assurance Committee, it's great to see that ethics, sir. Anything you'd like to add?
No, it just goes to show we've already completed some of the items there, especially you'll be pleased to know having a patient partner member now as a core member of the committee.
Okay, great. Any questions or perspectives on the QAC annual report for last year? Okay, thank you very much, colleagues, for your hard work in that. We'll move on then to some subcommittee chairs update. The first is a QAC from the 28th of March and the 25th of April and verbally the 23rd of May. Sarah, anything you particularly like to emphasise out of the written reports or the verbal update?
No, the things that I was going to mention from the verbal update were the improvement in the Saving Babies' Lives that we've already heard about from Lorraine. And just to note that in our last meeting, it references to the assurance of QAC, the previous item, that we weren't quorate because of a lack of non-exec members, and so that is something that we really do need to work on so we can make sure that we give full assurance to the board.
Thank you, Sarah. As you're aware, I'm trying to recruit some new NEDs to help in the capacity issues that we have. Any questions of perspectives to Sarah? Thank you, everyone, for your hard work. I know it is particularly tough at the moment, and Rosie, thank you. The Audit Committee of the 16th of May. Simon, anything you'd like to pull out of this report?
Just a couple of things. Thank you, Chair. The first thing to note is that there's a piece of work ongoing to look at governance below board level, which is an important piece of work to complete. So we're carrying on with that. Second, to note that we received the internal audit annual report and the head of internal audit opinion, and the opinion is moderate, which is a good outcome. So we're very pleased about that. And to date, there are no issues flagged from the external auditors in relation to the final accounts.
That sounds great. Thank you very much, Simon, for chairing that. Any questions or perspectives to Simon? And then we've got the improvement board from the 16th of May. Glenn, anything you'd like to emphasise?
Thank you, Chair. Just to highlight the alignment check we carried out relating to the impact national strategy for improvement, and in summary, we're very aligned.
Okay, that sounds good. And we did have that fantastic, which you referenced in your Chief Executive's report, improvement event across the whole of the foundation group, which was a multi-day sort of opportunity to share some of the real collegiate working that goes on in the foundation group across the 3 acute trusts to ensure that we are learning from one another and challenging one another to improve at pace and implement at pace. Any questions to Glenn? Okay, thank you. And so we've just got then the QAC minutes of the 28th of March and 25th of April for information only, and the Audit Committee of the 21st of March and the 24th of April, again for information only. So I think we're on to any other business. Any other business, please raise a digital hand. One thing I would like to do, Sarah, in terms of subcommittee timing, is to try and coordinate across the foundation group that the F&P meetings occur on different days, so that going forward, it may take us a while to do that, but at the moment I'm double booked on the day of the George Eliot F&P. Going forward, I do want to be able to attend all of the individual bits of the foundation group F&P days, just as an observer. So can I ask you to think about a piece of work with me behind the scenes, but just so the public are aware. Any public questions? I think we have had some, haven't we, Sarah?
We have, Russell, we've had two. So the first one is from John Young, who is with us today, and he's asked for an update on the long wait for the MRI scans being reported. I think Robin's got an update on this one. Thank you.
Robin.
Yeah, thank you, Chair. So Catherine's already mentioned this in the IPR report already, that we're fully aware of this and making significant inroads to improvements. So our waiting times for MRI reporting and CT reporting drifted out to a point of 15 weeks for MRI and 12 weeks for CT scans. That's not dissimilar to other acute providers. In that, one of the key drivers there, as Catherine mentioned, was the diversion of resource and time into delivering the tests themselves, and particularly around cancer patients. But I am pleased to say that the work that we've done, we've taken positive action in terms of identifying additional resource to support the teams from some insourcing work, which has enabled us to reduce the waiting times already from MRI's gone from 15 weeks to 8 weeks. So we've nearly halved that waiting time and on a trajectory to get back down below 28 days for reporting by the end of July. And for CT scans, we've gone from 12 weeks down to 9 weeks, and we anticipate being back again by the early July, back within 28 days standard for that. Just to note, the cancer patients within that, we've maintained a good turnaround of cancer reporting. So the current waiting time for an MRI report for a cancer patient suspected is 1 day, and for a CT scan is 4 days. So it has been the routine activity that's been affected. And also, just in terms of the common question, follow-on question around potential harm, we have performed harm reviews on all of those patients we've pulled forward as part of that backlog work, and there's been no harm identified, and also no unintentional findings of any of the tests that have been done created by a delay.
Thank you, Robin. Very clear answer. And Sarah, the second written question we've had.
Thank you. So this is from a member of public, Mr. Warwood, who isn't present today. And he said that given that COVID restrictions have now been significantly relaxed over the country, when will the Trust revert to meetings where members of the public will be able to attend in person, particularly the up and coming AGM? He's sure that the Trust board will agree that face-to-face attendance and possible interaction is better than virtual online meetings.
Okay, thank you, sir. I'm not sure I would actually agree with that last point, to be honest. I think that one of the things we've learned, and COVID was certainly the catalyst, was that there are different ways of working. And one of the real benefits of digital ways of working as we are now is it does allow maybe those members of the public who are less mobile, don't have access to transport, are able to join this meeting when otherwise maybe they couldn't. But also in terms of our carbon footprint as a board, being digital actually does save an awful lot of carbon, and it also does save money in terms of cost. And I think that the final thing is that certainly digital as a way of putting together multidisciplinary teams in the way we actually provide our services has, I think, radically improved the ability of various different people to come together in a far easier way and a more productive way. So I'm not actually sure I share the perspective. We are thinking about how we can, and members of the public should be aware, non-executive directors frequently visit the Trust to do visits, and so behind the scenes, if you like, things are very physical. The AGM, I think the argument is similar, but Glenn and I will certainly take away about when, if members of the public want to see us physically and see my tall, lanky frame in its full glory, we will think about how we can do that. But I'm not sure I share quite the premise of the question. Thank you, though. And David Carr, you've got your hand up. David.
Thank you, Chair. I saw the BBC item this morning on the impact that overseas recruitment of nurses is having on their own domestic need. And I was wondering if the model outlined by the Chief Nursing Officer of our recruitment methodology is going to be continued for the future with the good points that she made. Thank you.
No, thank you, David. David, I'm not sure if you get access to the chat box, but Sarah McLeod in that talked about the fact we do use an ethical recruiters list to ensure all our international recruits are from locations where ethically we don't think that there is an issue. I certainly do worry about the NHS's reliance on international nurse recruitment. I understand it being a expedient thing to do in the short term, but as a G7 nation, we should be able to train and recruit our own nurses from our own population. But Natalie, is there anything you'd like to add to my reply to David?
Just to say, Russell, that through the Chief Nursing Officers meetings, which we have on a regular, well, weekly, it is something that we do consider, David, and we look at that very, very closely and are always reviewing and updating it in line with the national.
Thank you for that reassurance.
Sorry, everyone. And any other questions or perspectives from members of the public? Okay, well, lovely to see you all. Look forward to seeing you at the next board meeting, which is actually hesitation. Sarah, when is the next board meeting? The 4th of July. Look forward to seeing you on the 4th of July, Independence Day. And then at the beginning of August, we have our, again, Foundation Group public board meeting. So I hope members of the public are able to join us then as well. In the meantime, for board colleagues, I suggest we have a comfort break, get back together again at 4. Rebecca O'Connor, if you want to join us for the confidential board, you're very welcome. Thank you very much, everyone, and thank you for all of your endeavours for the citizens of Warwickshire North. Take care.